Good afternoon. I have not much disclosures, except that to let everyone know that I don't intend to reopen the American economy next week. And all I have learned, all I'm sharing today, I learned over the past 3 months or so. So right now we are maybe about going to the 4th month into this COVID situation. And to me, I think we've actually more questions than we have got solid answers. And the questions I would have is that there are zombies in our midst, and we just cannot identify who these zombies are. We know that there's asymptomatic spread, pre-symptomatic spread. Swabs may be false positive. People who have been infected, recovered, and reinfected and start shedding the virus once more. So there's lots of stuff which we don't know about this virus, yes, about how it transmits, and even why some of us seem to get it much worse compared to the rest. So, and this is just one patient whom I encountered, which really drives home the point to me. He was swabbed like once every day for about over the course of 2 weeks, and the swabs will occasionally be positive. So that to me is a very, very worrying sign. But as what Jyoti said previously, as the disease progresses and the virus from the nose and the pharynx goes down deeper to the lungs and the bronchi, then it gets harder to get a positive swab without there being a really good sample. But we can't intubate everyone to get a good sample. So what it tells me is we really need to have very good protocols in place for us to detect these zombies, because we are not afraid of the known zombies. It's the silent zombies which should scare us all. All right, and the next thing that everyone is fearful about is it airborne? Is it not airborne? And I think it is almost certainly for now not airborne, because if it was airborne, many more of us would be infected. And I am sure we've all been to this. We all go to this website like once every day and freak out when the numbers have jumped once again. And even then, the R0 for the coronavirus is less than 5. So I think it's not airborne. So it's mainly droplet. So if it's droplets, like what was said previously, we just need to wear a mask and we need to have hand hygiene and wear PPEs that will protect our exposed mucous membranes. And we need to maintain a fairly safe distance. If it was airborne, then we swap the surgical mask for the N95 mask, and we try and keep them in the rooms which are negative pressure. The overlap comes during the aerosolizing procedures that we talked about. And this is a list from the UK, and they've actually quantified it such that and ranked it such that the most aerosolizing procedures are tracheal intubation, non-invasive ventilation, all the CPAPs, BiPAPs that we do in the ward. We may want to think twice now. Like in the past, we used to say, oh, this patient seems to be deteriorating. Let's see if we can stave off intubating and positive pressure ventilation for a few days. But now it seems like that may not be a wise decision, because that may aerosolize his viral particles, and staff and patients around him may be put at risk. This is another view of airborne and droplet spread. So when talking and breathing and sneezing and intubating, we produce particles. Most of them would be greater than 10 micrometers, which would be less of a problem to us. But if it's less than 5 to 10 micrometers, then it becomes a problem, as it's able to penetrate deep into the deep into our bronchi and the respiratory system. So, assuming we are doing an aerosolizing procedure, we talked about PPEs, and at the same time, we are also we can also institute some engineering control measures. So Raj talked about the negative pressure, and this is a close schematic diagram of the negative pressure room, which Raj talked about. And if you see here, so although we say the room is negative pressure, the operating complex itself, the MBOT-15, where the surgery is conducted, is actually still at a positive pressure. So this ensures that, you know, there's no risk of wound infection to that individual patient. But what is negative pressure is the rooms that are actually adjacent to the corridor. So the induction room and the antechamber are negative pressure, which means that when the door opens, when the OT door opens, air from the OT will rush into the antechamber. And when the corridor door opens, air from the corridor will rush into the antechamber and it will keep the contaminated air in. This knowing your airflow and where your negative pressure is very, very important, especially when it comes to the donning and doffing. So I will go into that in a great more detail, but suffice to say, for us, we will remove our PPEs, the yellow gowns that you saw. We will remove them in the antechamber, but we will keep the PAPR on. We'll keep the yellow gown. Sorry, we'll remove the yellow gown in the antechamber. Keep our PAPR and N95 on, and only after we go out to the corridor do we take off our PAPR. Then one word about air exchanges. In our OT, we have the air exchange about 20 times every 60 minutes. That means one full air exchange every 3 minutes. So one full air exchange will reduce the viral load in the air by about 63%. So by about 5 air exchanges, the concentration of viral particles in the air would actually be less than 1%, which means that if you have staff which are not protected, they should not be anywhere near the intubation and the reversal. And where possible, if there is luxury of time, the staff should actually enter after 15 minutes after the air is secured for maximal safety. Although the staff entering our OT complex would already be wearing the N95 mask anyway, so most of the time it's all pretty safe. So so we are now talking about zombies and how do we ensure that we do not select a zombie for surgery. So we have had a case whereby in a neighboring hospital, a patient had a lab chole done. 3 days later, came down with a fever, and then was later on diagnosed to have COVID. And at that point in time, the staff in the theater, some had N95s on, some had surgical masks on, and because of that, quite a few people in that surgical team had to be quarantined for 2 weeks. So we don't want such a situation to happen, because uh, uh, in these situations, healthcare workers are the assets which you really need to protect, because with us working, we are a force multiplier. When we fall ill, not only can we not help, but we are adding to the weight of the problem. So for us, for any suspect or confirmed case, we would, if we start from the top square, so any suspect or confirmed case, if it's yes, we ask ourselves, can the surgery be delayed for 2 weeks? If the surgery can be delayed for 2 weeks, well and good, let's postpone him. In the non-COVID recent past, like let's say 4 months ago, we actually would have proceeded with cancer surgery, because the concern then was, if we postpone him now, will he have an operating slot in 2 weeks' time? So therefore, in the past, even when the patient had a slight flu, we would actually have proceeded. But now things have changed slightly, as in workload has come down quite a fair bit. So we now have no problems finding an operating slot 2 weeks from now. So our preference is to postpone surgery till after the patient recovers fully. So if the surgery can't be delayed, or if the patient has got some acute respiratory infection, or if the patient has had some close contact with a suspect or confirmed case and the surgery cannot be postponed, then we will perform the surgery in that COVID theatre which we talked about previously. So other than the N95 mask and goggles, we also don the PAPR during induction and at reversal. Our stocks of PAPR are fairly limited. So each theatre only has 4 PAPRs. So at that point in time, anyone within 2 meters of the patient will have a PAPR on, and anyone who has no business being in the theatre is asked to leave until they are told that the coast is clear. And moving on to the green column, so all other seemingly healthy, happy human beings, we will treat them as possible zombies and still proceed with surgery, induction with N95 and some form of eye protection. So we have talked about this: full PPE, eye protection, N95, long sleeve yellow gown, gloves, and as well as shoe covers. Just a short word about PAPRs. We talked about it a lot. There's a worldwide shortage. We have very heated discussions about buying of PAPRs, deployment of PAPRs within the hospital. But actually, there is not much scientific evidence about PAPRs and how protective they can be. Of course, in the same vein, there is not much scientific evidence to support the use of parachutes, but most of us would want one when we decide to jump off a plane. What I could find was that if you have a PAPR, this additional hood that you have forms another layer, preventing droplet contamination of your gown beneath this hood, and this may prevent infections. But donning a PAPR does come with at a cost. Firstly, with the whir of the blower, it makes communication quite difficult. And if you look at some of these hoods, they are full bodied hoods. So for us, there was a question in the chat just now about when we are in Theatre 15, how do we communicate with the people on the outside for us to get our equipment? So our OT runner has got a phone, And using the landline from the inside the theater, we do call out to request for drugs and equipment. But with these, you would be holding a phone to the external surface of his ear. So there'll be one layer, and you add to that this blowing sound, like from the top, like a soft hair dryer. So it does make communication quite difficult. And if we are using it for a ward round, I don't think you'll be able to hear the crackles very, very clearly. And of course, in a code blue situation, there will be donning and doffing delays. We timed it, and the average time added on putting on a PAPR is about 3 to 4 minutes. So in a code blue situation where someone is already doing CPR, and if you can see that patient clearly needs to be shocked, perhaps some would consider entering with the room without a PAPR, although I personally would think that if it was me, I would want to protect myself and my staff, because if one of my staff is down, if the whole ward of like ICU nurses, whole shift of ICU nurses gets quarantined because of one heroic act, then it may not be worth the cost. So having said so much about the PAPR not being proven to be useful, why do we cling so tightly to it? And I think it's because we first started using the PAPR during SARS, and we found that actually those who use the PAPR didn't come down with SARS, and so I think if something worked for you, we tend to cling on to it. And this COVID-19 infection, to me, it seems a bit more infectious than SARS because of these silent zombies, you know. So you don't know who's going to be ill. So you don't know whether, without using the PAPR, have you been indirectly infected? And for the next 2 weeks, you may be going around infecting your whole department. Moving on to the general OT setup, as Raj said, we tend to minimize everything, which means it's minimizing everything and maximizing frustration to the staff in the OT. So as a surgeon, if you're going to do a bowel anastomosis, we will not bring in the stapler that you want until you're very sure that that's the stapler that you want. And when it's brought in and you realize, oh no, I need another stapler, or I need another Hemalock or something else, then unfortunately, we need to call the runner to bring it in. So everything in the in this theater takes longer to happen. The patients will be brought to the OT directly, not passing through reception. And once surgery is done, they will be brought out. Sorry, they'll be recovered in the OT itself and discharged directly back to the ward without passing through PACU. And once the patient leaves, then we would clean the OT thoroughly. There was a question about what do we use in our hospital. So we use these. I'm not exactly sure why one is used for one surface and not the other surface, but I'm sure they will all be virucidal, but just that some may spoil your screens. So just one slide about what to do regarding anesthesia for COVID. So we will generally avoid high flows. So even in the ward, if you have any patient who is deteriorating, even in the ED, usually principles of resuscitation, high flow, 100% O2. In this case, I would run sufficient O2 to keep the sats about 97 to 100%. Because bearing in mind, if the flows are high, if at that point in time the patient should cough, then that high flow O2 acts to as an aerosolizing agent to push these viral particles further from the patient. We try to avoid circuit disconnections as far as possible. If we know the patient is going to the ICU post-op, we will request for the ICU ventilator to be brought in, and then we will use the ICU ventilator and transport the patient back to the ICU with the same ventilator. If we do have to disconnect the endotracheal tube, we will clamp the ETT before we disconnect. Like what Raj says, COVID time or the COVID patient is not the time to learn. So the most experienced person will take the airway, choosing a plan which will work. Okay, our plan A is a plan which will work to secure the airway at first pass. And once the airway is secured, assuming there is minimal leak to the system, then actually risk to the surrounding staff is minimal. And then at that point in time, other staff can come in without any PAPR. And again, at the end of surgery, we do the reverse. We chase all the staff out, put on the PAPRs once more, and we extubate the patient. As soon as possible, we put on a surgical mask for this patient, and then we discharge patient after about half an hour if the patient is stable. I think this is my last slide. So, so what I said just now about Donning and Doffing protocols. So we have a room that is designated negative pressure. That's our go-to COVID theater. But we have actually designated another theater as the standby theater, just in case there's a rush-in Caesar which cannot wait. So that is actually our theater 16. All other theaters in our theater complex are positive pressure theaters. So we have actually designated theater 16 as a negative pressure room, which means the OT complex itself, it's all the rooms in the OT complex, the pressure is equalized to the corridor pressure. So when doors open, no air moves in or out. So in such a scenario, we actually have chosen to don our PPE at the Blue Star before we enter the surgical complex, and we will doff our PPE in the induction room. Okay, that's all I have. I will be